Well, we're coming up to the hour in about 30 seconds. I'll give people those 30 seconds to take that last bite of lunch or cup of tea or coffee, what have you. But I'm really glad to be looking at this next panel. I think if folks have been listening heretofore, you got from our keynote panelists and our health benefit design panelists a real strong foundation for how the heck we got here with these disparities and these oftentimes gross inequities. And I might add that it's very interesting, at least to me, that a lot of these activities among organizations was actually prompted by what the pandemic wrought. Was prompted by the George Floyd murders. These things have been cited many times. And so it's interesting how epidemiology and current events and kind of disrupted economics can prompt us to, can shake us up a little bit to make us start thinking about these issues. And just to get started now, anybody who is online with us now can't fail to appreciate, we've got a lot of experts on this, exactly the issues arisen with pharmacoequity. It's been in the news yesterday, today, and tomorrow for some high profile issues, but this thing's been going on for a while. And if you really wanted to pick out an area where there's a lack of equity, you don't do a lot worse than trying to take a look at the cost and availability of pharmaceuticals. And so with that, we have a great panel that's going to address advancing pharmacoequity and enhancing access to essential medications. And I think that our three panels are quite experienced and know our particular drill about self-intros, after which we will go to our three-part stories. Jalpa, could you get us started with sort of name, title, affiliation, and how you find yourself in this panel? Jalpa. Jalpa, we can't quite hear you. Is your volume down or are you on mute, perhaps? Can't quite hear you.
Thanks, Cliff. Can you hear me now? Yeah.
Absolutely.
Good afternoon, everyone. I'm Jalpa Doshi, a professor of medicine and a senior fellow at the Leonard Davis Institute of Health Economics at the University of Pennsylvania. I wear two other hats at Penn that are relevant to this panel. I serve as the Director of Value-Based Insurance Design Initiatives at our Center for Health Incentives and Behavioral Economics. I also serve as the Director of the Economic Evaluations Unit at our Center for Evidence-Based Practice. I have been at Penn for about 20 years, and the goal of my research program has been to understand how prescription drugs can be better accessed and utilized in the healthcare system so as to improve healthcare outcomes and quality for all patients while balancing costs. My work to date has informed prescription drug policies for both private insurers and public programs, and I look forward to talking about the implications for enhancing access to essential medications and advancing pharmacoequity on our panel today. Thank you.
Good afternoon. I'm Amy Niles. I'm Chief Advocacy and Engagement Officer at the Patient Access Network Foundation, commonly referred to as the PAN Foundation. I'm grateful to be here alongside my colleagues Jalpa and John this afternoon, and thank you to Mark Fendrick and the VBID Center for including PAN. The PAN Foundation, for those of you not familiar, is a national nonprofit organization that since 2004 has provided an important safety net for people who are underinsured by providing financial assistance to cover out-of-pocket costs for prescription medications. The individuals we help are living with life-threatening chronic and rare diseases, and without financial assistance, they likely would not be able to begin or adhere to treatment. Most of the people we help at PAN have federal insurance, such as Medicare, and these are the individuals who have great need. They're living with one or more chronic conditions, and they have been prescribed often specialty medications that come with very high out-of-pocket costs. Additionally, for people on Medicare, they're unable to receive financial assistance directly from pharmaceutical manufacturers. So the safety net that the PAN Foundation provides is really important. My role at PAN is to collaborate with external patient and provider organizations to really educate them about the world of patient assistance and also to lead PAN's advocacy and policy work. Advocacy is a huge part of the PAN mission, and we've been pretty active over the last few years. Long story short, PAN is about access and affordability, and that's why I'm here today. As Amelia Kaufman, a prior panelist, mentioned, removing financial barriers is only one way to address health equity, but we know it is a very important way.
And thank you, Amy. We're very interested in hearing some of the stories about how deeply entrenched you are in the community and how you've translated that into policy action. Let's move over to John over at MPC. John?
Thanks, Cliff. I'm John O'Brien. I'm the president and CEO of the National Pharmaceutical Council. We're a 70-year-old health policy research organization supported by the pharmaceutical industry. We do research to advance patient access to innovation, and we focus on a lot of important topics, including the one that we're going to talk about today. I'm a pharmacist by training. I've worked for drug companies, health plans, and the government, including most recently as senior advisor to the HHS Secretary for Drug Pricing and Deputy Assistant Secretary for Health Policy. And I'm here because this is an important topic, and it's something that we focus on. It's something that our members focus on. And of course, I'm a big fan and longtime supporter of the center. So thanks for having me, and it's great to join this panel with Amy and Jalpa.
And thank you very much, John. We're looking forward to hearing how you and actually your member organizations are approaching this issue. If NPC and its organizations can take a lead, that can have a great effect downstream. Jalpa, let's move back to you. Jalpa, I know you're kind of the economist, academician, and a whole bunch of other hats I know that you wear. Can you tell us how you and or your organization have been prompted to jump into this issue? Jalpa. I think are you back on mute, Jalpa? We can't hear you yet.
Sorry, too eager to talk. Forgot to ask. When you post these great questions, I was thinking there is so much to talk about and so little time. So I'm going to take a slightly different tack in terms of focusing on one specific story about my research team's work in the area of fixing Medicare Part D cost sharing policy to enhance equitable access to specialty drug treatments. So let me start by saying that the need to address the issue of improving access to medications came to my attention more than 20 years ago when I was working on research that ultimately supported the creation of the Part D drug benefit under the Medicare Modernization Act of 2003.
You were there.
Yeah, and while that was very exciting to see at an early stage in my career, it became very quickly apparent to me that there was going to be a lot more work to be done to get things right. And why was that? Because the cost sharing requirements under the Part D benefit were so poorly designed that they would continue to result in medication access barriers and disparities for many beneficiaries. Now, my team's early work on Part D after its implementation in 2006, like many other researchers, focused on traditional drugs. And the infamous donut hole issue, or what is the Part D coverage gap phase, got the most attention. Congress was quick to act, and they basically tried to fix the donut hole issue through the passage of the Affordable Care Act in 2010. And while this was welcome news, I was quickly noticing that there was an ongoing trend that made it very clear that the remaining issues with the Part D cost-sharing design were going to generate major issues for those needing specialty drugs. So what was brewing? There were a number of factors. The number of specialty drug treatments that offered therapeutic advances over traditional medicines was increasing rapidly across multiple disease areas. Second, many of these novel drug treatments cost tens of thousands of dollars. Third, even after the donut hole fix, the Part D cost-sharing structure required patients to pay 25% to 33% co-insurance. Mind you, not a fixed co-payment, but 25% to 33% co-insurance of the cost of these specialty medications. And then there was no annual out-of-pocket maximum, and patients had to continue paying a 5% co-insurance in the catastrophic coverage fees. To add to that was a fourth point that we were already aware of the large racial ethnic disparities in the income and assets of Medicare beneficiaries. So the lack of affordability for the very high out-of-pocket costs for specialty drugs under Part D were only likely going to exacerbate the inequities in access that already existed. So it was a perfect storm in the making. But what I noticed was that it was not on the radar of anyone's. What I did was I pivoted my entire team's research into the specialty drug area starting around 2011. Now, over the next few years, my team engaged in multiple activities. And what did we do? I guess I would bucket it into 4 different areas. First was to essentially highlight the problem. 2 was to show the negative consequences associated with the problem. 3 was to propose policy solutions on how to fix Part D cost-sharing issues to address the problem. And then the 4th was to actually disseminate this work to reach the audiences that could really make a difference. So the first area kind of involved conducting real-world research and simulations to highlight the problem of the too much, too soon out-of-pocket costs that occurred under Part D for specialty drugs. The too much problem showed that specialty drug users spend thousands of dollars out of pocket in the year, and nearly half of this annual spending was actually occurring in the seemingly low 5% catastrophic coverage phase. Thus, the lack of an annual out-of-pocket maximum was a critical issue. The too soon problem showed that the Medicare Part D out-of-pocket costs were all front-loaded at the beginning of the calendar year. So we illustrated that even if an annual out-of-pocket maximum of $2,000 was put into place, the 25% co-insurance requirement would result in a Medicare beneficiary having to pay the entire $2,000 in January alone if they were using an expensive specialty drug. This was a critical issue because many Medicare beneficiaries, as Amy will tell you, cannot afford to pay that kind of money in January at the beginning of the year. So the second area that we then moved on to was saying, okay, let's take this too much too soon problem and see how this connects using real-world Medicare claims data to show the negative consequences of the cost-sharing burden that Part D was generating. And what we found here was that a series of studies essentially showing that Part D cost sharing for specialty drugs was resulting in high rates of prescription drug abandonment, delays in treatment initiation, non-adherence, and early discontinuation of specialty drug treatments. So we ended up generating this whole body of evidence, essentially showing this was a problem and it was generating negative outcomes in the Medicare population. So we then moved on to saying, fine, we've described the problem, but we also need to come up with policy solutions. So in 2016, we came up with one possible way of addressing this. And the solution was an annual Part D out-of-pocket cap combined with a monthly cap to distribute these costs more evenly throughout the year, which has now become to be called smoothing. With an annual out-of-pocket cap of, say, $2,000 and smoothing in place, patients would now be able to spread out their $2,000 that was owed in January over the entire 12 months of the year, essentially requiring patients to pay just about $167 per month. But then what we needed next was to kind of move this from the traditional academic publications and scientific conferences to the stakeholders who could really make a difference. And this is where we kind of worked in a fourth area of using multiple dissemination strategies. A big shout out to the PAN Foundation and the American Journal of Managed Care, who put out national competitions in 2016 and 2017, asking researchers to submit papers and policy solutions to solve for these problems of cost sharing and access to essential medications. We participated in these competitions, won awards, but most importantly, we had the opportunity to present these policy solutions in front of an audience that included patient advocacy groups, policymakers, and other stakeholders. And the PAN Foundation was among the first to take on our policy recommendations as their official advocacy position. And quickly, other organizations also kind of took on the same position. We also wrote blogs and commentaries. We participated in panel interviews at healthcare events at the Hill. We also partnered with the PAN Foundation to create an infographic that could kind of convey in a very digestible format what the issues were, particularly for specialty drug users, and how they needed to be fixed in terms of Part D cost sharing policy. The PAN Foundation shared some of these materials with congressional staffers and in written testimony. And so as a result, and the outcome of our work and our other researchers and organizations like PEN and many, many other stakeholders, what we've seen is the passage of the Inflation Reduction Act last year that incorporated this idea about an annual out-of-pocket maximum combined with smoothing as part of the implementation, which will go into effect starting January 1st of 2025.
Well, Jalpa, that's a great story. And you had a great beginning, middle, and end, although the end isn't a forever end.
Yes, the end was supposed to be I would retire, but now the Inflation Reduction Act is in place. I'm actually very energized to make sure that we make sure that it is implemented correctly in a way that it does indeed reduce disparities in access to specialty drugs. Yeah. And Amy and I have co-authored a health affairs blog last month on the same topic.
That's great. This is interesting because what you covered is, and again, as noted, you started at the beginning here, you focused early on poorly designed cost sharing for Medicare Part D. You saw the donut hole. The donut hole led in part to parts of the ACA, but you spotted early the trend vis-a-vis cost sharing for specialty drugs in particular. And then we like the four-part approach: problem identification, too much too soon; show the negative consequences. You use real world evidence to show the impact on outcomes; potential policy solutions. You looked at an annual cap and then the monthly cap, which we now know is smoothing. And you put that out with dissemination and partnerships with outfits like American Journal of Managed Care and PAN. You mentioned the competition for policy solutions. And there you have something in the Inflation Reduction Act. That is a very tight-knit, though still incomplete story. Jalpa, thank you very much. Well, since Jalpa mentioned PAN, it's time to go to Amy Niles, who will pick up the story, as it were, in her own way. Amy.
Great. Thank you, Cliff. And, it's always an honor to work with Jalpa and her team at UPenn, because the research foundation is critically important to this work. So, since 2004, we've heard from many patients and many providers about the challenges that patients face relating to high out-of-pocket costs for their medications. And as I mentioned earlier, we have particular concerns for people on Medicare who, up to this point and through the end of this year, will be the only group in the United States that don't have a cap on what they spend out of pocket for their prescription medications. We see these concerns exacerbated every single year in January, when our call center is flooded with inquiries from patients because their deductibles are resetting. And I always like to use this example. Imagine the 80-year-old who is living on a fixed income of maybe $30,000, and he or she has to afford their living expenses, have to put food on their table, and on top of that needs to afford thousands of dollars for their specialty medications. For years, we have felt that reforms to the Medicare benefit were needed and could address some of the affordability challenges for many. Over the years, we have analyzed our own data here at PAN, and it's become evident to us that we truly are supporting and helping people who are falling through the cracks. So we're helping the people who are not eligible for the federal low-income subsidy program, but they are at very low income. They're between 150 and maybe 250 or 300% of the federal poverty level. And they're coming to us from every single state and territory in the United States. After speaking with hundreds of patient and provider groups over the years, it's still the case that so many people are simply not aware of the important safety net that may be available to them, especially people on Medicare. So as a result, we've spent a lot of time at PAN educating patients and providers about charitable assistance, about patient assistance in general, and for advocating for reforms that can have an impact to lower out-of-pocket costs. We need to do more, and I'll speak about those reforms in a moment. Just to make a comment on the commercial side, there are also issues relating to access to medications. In recent years, we've become quite concerned about the expansion of copay accumulator programs, and we believe that these programs prevent access to needed treatment. They are policies that say that the value of patient assistance, such as the value of drug coupons, won't count towards someone's deductible and out-of-pocket maximum. We feel these programs are discriminatory and should be abolished. And finally, also on the commercial side, Mark Friedberg talked about the high deductible health plans, and certainly these plans also have the potential to impede access. So let me now speak to the ways that we're addressing pharmacoequity at PAN. First and foremost, as Jalpa alluded to, we've been a strong advocate for Medicare reforms, which include the Part D cap, include smoothing, and include the expansion of the low-income subsidy program. We've spent a lot of time with members of Congress and their staff along the way to educate them about the importance of these reforms. So we really felt great for the patients across the nation when the Medicare reforms were finally enacted in August 2022. Sometimes I feel like it's still a blur and still not real, but we're very happy. But our work is not done. PAN is playing a major role to educate patients and providers about these Medicare reforms. We've developed a comprehensive education hub on our website. We're striving to bring this notion of smoothing that Jalpa talked about into the mainstream discussion. It simply has not been in the headlines, and that's one reason why we work together on the Health Affairs blog. We're having ongoing conversations with CMS about smoothing, in particular, Medicare reforms in general. We want to make sure that as the smoothing reform is implemented, there are standardized patient protections, which right now are lacking in the language in the IRA. We want to make sure there's standardized language that all plans can use. And we want to make sure that there's easy ways for patients to opt into this program. We're also actively working alongside the National Council on Aging with CMS to identify opportunities to streamline and facilitate enrollment in the low-income subsidy program. One thing that's really important with the Medicare reforms that I believe strongly in, no one should get complacent and feel like, the work is done. We still have issues to address. And, in fact, when the reforms were first passed in August, we actually started hearing from many patients who said, the Part D cap is great. It'll be a big improvement, but $2,000 is still a lot of money for me. They quite frankly said, we hope PAN's not going to close their doors because people might think charitable assistance is no longer needed. So We're not closing our doors. In fact, we think we're going to be working a lot harder to develop new programs to offer financial assistance to more patients. But because we were hearing these concerns late last year, we commissioned some research from Avalere Health to just take a look at the hard facts about how many Medicare beneficiaries will experience out-of-pocket costs up to $2,000. And what that research uncovered was that more than 2.6 million non-LIS, low-income subsidy Medicare Part D beneficiaries will have out-of-pocket spending up to that $2,000 cap on prescription medications in 2025 when that reform goes into effect. Furthermore, about 800,000 beneficiaries in 2024, more than 200,000 in 2025 will spend more than 10% of their income, on prescription medications each year. On top of the Avalere research, we also did some national polling just to gain some public opinions and perspectives on this issue. And what we found, unfortunately, is that about 75% of adults polled said that it would be difficult to afford $2,000 in out-of-pocket costs. Concerns were particularly high among Black adults, Hispanic adults, people with very low income, people living with multiple chronic conditions. And of those that have not had the need to spend that level of dollars for their prescription medications, if faced with that, 6 out of 10 said in order to do that, they would probably have to limit the amount of food that they put on their table. So the analysis and the polling reinforces, at least for us, that we think there's going to be continued need for financial assistance and that the PAN Foundation will continue to play a critical role providing the safety net. So we're to further address the equity issue, we're doubling down on our copay work. We have hundreds of diseases for which we would like to provide financial assistance for. We're also continuing our work to collaborate with a wide range of patient and provider organizations that are focused on serving the minority communities. So to kind of close out and speak to our goals and our hopes at PAN, we believe that charitable assistance is one strategy that can advance more equitable health outcomes by ensuring that those who are most in need have access to the medications that they need and the medications that have been prescribed by their healthcare providers. But again, we don't want anyone, including members of Congress, other stakeholder groups, to get complacent and believe that with the Medicare reforms, the work is done and access has been addressed. Our goal is to make sure that we are able to fill that gap for the many people who come 2025 still believe that $2,000 will be a hardship to afford.
Yep.
Finally, in closing, we're building new partnerships so that Black adults, Hispanic adults, Asian Pacific Islander adults, people with disabilities who are on Medicare, LGBTQ plus community, those in rural America have access to the care we need. For example, we've just formed a strong partnership with the National Rural Health Association. And we're very pleased that we've just brought on a dedicated Chief Diversity and Health Equity Officer at PAN. She's going to be instrumental in creating our health equity strategic plan, which among other things will potentially include reaching out to providers that are supporting these minority populations and looking at more partnerships at both the national and the community level. Okay. Over time, we'll measure success if we're able to improve access to medications for more people who have traditionally been underserved.
Well, Amy, thank you very much. Just listening to you, it's apparent that it's kind of a whack-a-mole thing. I mean, you think you kind of sew up an issue in this part of the population and then something else pops up. And so you outlined very, very well your attention to the Part D cap, your attention to smoothing, but you still need to bring that to the national attention. The low income subsidy issue is still out there. It's not going away. And you're warning us that, Medicare reform is good and we like the IRA and so forth. But when you look carefully, as you have, and you've done and commissioned the research as you have, there are pockets of hundreds of thousands and millions here and hundreds of thousands of people there that have incomplete coverage, whether it's that very tough January, that really tough month in January, or hitting caps. There's just too much to do. And so what you're saying then is, and this is for the foreseeable future, we need charitable assistance. That cannot go away. And in order to sustain that issue, you're forming new partnerships to make sure that PEN is providing a broader array of services and just being able to focus attention on making sure we continue to close these gaps. So much appreciated. Thank you. That's a big load of work there, Amy. All right, let's move on to the National Pharmaceutical Council. John, tell us about whom you represent, and then tell us how this came to your attention, what you did about it, what you're seeing. John O'Brien.
Yeah, thanks, Cliff. And Amy, I might have laughed out loud. I feel like every 5 to 10 years, someone says that your mission has been achieved, and then we discover how much you need to do. So thanks for the important work that you do. Again, I'm here on behalf of the National Pharmaceutical Council. We're a 70-year-old health policy research organization supported by pharmaceutical manufacturers, many of whom I can see are part of the great audience that you put together. So really honored to be here on behalf of NPC and have them on our board. There's one other person in the audience that I'd like to thank in particular. Health equity has been on our radar for quite some time, but we have really doubled down on it since hiring Gabrielle Shabazz as a researcher. So Gabrielle, thank you for pushing us and for helping me prepare really much of what I'm going to say today, Cliff. For example, Gabrielle taught me that the term pharmacoequity is actually relatively new. It was coined during the pandemic when we learned that Black and Latino populations were disproportionately being affected by the pandemic. But if we step back from COVID and look at virtually any disease state, from diabetes to heart disease to mental health, we can see differences in prevention, in detection, in access, and treatment quality that have a link to 3 significant forms of bias, either socioeconomic status, race, or gender. So while the pandemic brought these alarming disparities to the forefront, they've long existed before the rise of the pandemic, even with the United States paying more for medical care than any other country in the world. So for many, COVID was the sounding alarm, but not for NPC. So we've long been committed to conducting robust health policy research that more recently puts equity, and not just pharmacoequity, at the forefront of our work on innovation, value, and access. We've seen these disparities and we've described them in our previous research, our current research, and we're going to continue to do so in the work that we have ongoing. And this is something that's very important to our member companies, and they've done their own research on it as well. So while Dr. Essian's definition of pharmacoequity focused on creating a health system where all patients, regardless of race, class, or availability of resources, have access to the highest quality evidence-based medical treatment, the reality is that non-white individuals are more likely to experience and be affected by health inequity. So we can't ignore that. It's a focus of much of our work, and that's why we're here today. Now, as I mentioned, all of our members are committed to this topic and have contributed significantly to advancing this work, both with their financial resources as well as their intellectual and human capital. So we're proud to be an important convener of their work and also to do our own research alongside them. So for example, I think it was June of 21, we hosted a health disparities showcase. So our member companies showed up and they presented their research highlighting what they were doing on this topic. And we heard innovative studies and work around benefit design, access to coverage, access to and utilization of care, and things like disease-related complications. And it was interesting to me because it was both research, like, hey, this is what we looked at, this is what we found, but it was also action, like, and this is what we're doing as a result of it. So what we saw was that not only do our member organizations recognize the importance of and need for equity-related research and work, but that they're also committed to creating a knowledge base to facilitate more research, more development, and more action. And the same can be said for us at NPC, not only in the research that we conduct, but what we do and who we work with after that research is published. So while internally we are conducting research relating to improving access to appropriate care and addressing the cost of care, we want to make sure that that research has a chance to be useful. So for example, we found that wage status has a significant impact on specialty drug utilization and overall healthcare costs. In all but the top wage category, non-white individuals or employees in this case with autoimmune conditions were generally less likely to fill prescriptions for specialty medications for their conditions than their white counterparts. And they ultimately had higher hospital admissions and ER use. So the population of folks who needed the medicines most were using them least and ultimately costing the system more and suffering health-related complications from that. These findings revealed concerns about the potential contributors to many of the inequities that we've talked about today, like benefit design, enrollee health literacy, and provider prescribing bias, which can be a contributor in both under and over prescribing of certain medicines for minority populations. What we realize as we conclude each project is that more research is needed to identify and meaningfully address these drivers of disparities. And we're actually in the process of continuing the work that I just described with sort of a separate piece that focuses on the impact of something that Amy talked about, which is copay accumulator adjustment programs and their effect on specialty drug utilization and healthcare costs. I don't want to get ahead of the research team, but the readouts I've seen suggest that this affects people of color worse than it affects a matched white cohort. Now, let me be clear. I don't think it is right that insurance companies take money from patient assistance programs and don't let patients apply it to the deductible. It's especially worse when plans stop covering these drugs altogether and send people to the PAP programs. That's not what Senator Kennedy had in mind when the Affordable Care Act included drugs as an essential health benefit. It's wrong for many reasons. But one reason, and one of our members recently completed some research that found that copay assistance has the potential to narrow disparities in prescription abandonment for commercially insured Black or Hispanic patients taking rheumatoid arthritis medicines and patients with household incomes below $50,000. And if you were at AMCP last year, you saw another one of our members publish a similar poster. So we know that this isn't just bad practice. We know that it's contributing to inequities. And that's why I want to see our research used to change policies that improve access to copay assistance where needed. For many researchers, publication's the goal. At NPC, we want to do high quality research that makes a difference. We know our work around the importance of first dollar coverage for drugs that prevent the worsening of chronic disease for patients in HDHPs in the hands of caring and active people like many of those on this call actually was capable of changing policy. So that's just one example of research in the hands of advocates making a difference. So you'll see us taking our research on access with a focus on equity on the road so that we can share it with employers and others so that policy and benefit design can evolve to close these gaps. Now, I'll wrap up quickly by saying that our research reveals that barriers to medication access exist at the patient, provider, and health system level, and the same can be said for access inequities. So let me go back to where I started. We have an intelligent, active, and engaged audience at this event. And I see people who know this too well and are advocating for change. And that's why we're so excited to be here today. The term pharmacoequity may be relatively new, but our equity-related research and discussions are not. So moving forward, Cliff, our goal is to be part of the solution by working with our members to continue to not just do novel research, but package it so that it can be useful to others who want to be sure that everyone benefits from innovation and the value of medicine.
Well, John, thank you very much. And it's much appreciated as well that you're helping to ensure that NPC's research agenda focuses on research with practical applications And I know that you get input from outside stakeholders in designing that research, especially interested in the suboptimal prescribing and utilization of pharmaceuticals. People are getting the wrong prescriptions, and even when they get the right prescriptions, there's underuse or abandonment and other issues. It's fair to focus on the copay accumulators. We don't think all the answers are in on those things, but we're glad that you're focusing research on that. And it's also good to see that barriers exist, that you're appreciating that barriers exist at the patient level, the provider level, and the system level. So keep on your group, your research agenda. I hope you'll continue to share the agenda and getting input on the research agenda from others, and that you'll engage some of these folks and a broad group of stakeholders in the research itself. So that's very helpful. Had a question here for Amy Niles, and interesting question, Amy. The idea is here that how are you sure that your charitable stuff goes to the people most in need? The questioner is saying, gosh, people that are better educated and well off know how to navigate the system, and they'll get to your front door first. What do you say to that, Amy?
Well, thank you for asking that question. And we are, many of you may know, charitable foundation like the Pan Foundation operates under a highly regulated environment, and we operate with guidance from an advisory opinion issued by the Office of Inspector General. So the eligibility criteria across all of our approximately 70 different disease programs that we provide assistance for are very, very similar. And it is all first come, first serve. Across the board, someone needs to be treated for the disease for which they're looking for assistance. Their medication is on the program's formulary, which is all FDA approved generic and brand medications. They're residing and receiving treatment in the United States or territories. They have insurance. Some of our programs are only for Medicare beneficiaries. Others are for anyone, either federal or commercially insured. And you're at or below 400 or 500% of the federal poverty level. So again, first come, first serve. And as I mentioned earlier, when we look at the data, we actually are helping our most vulnerable, because the people who are coming to us are at the very low end of that FPL scale.
And a quick follow-up, Amy. When you talk about charitable assistance, does that include Part D, LIS, or others? Like which populations at risk are getting your charitable assistance?
Yeah, it's when you look at Medicare, you have if you're insured by Medicare, you're eligible to receive assistance. So if you are below 150%, we can provide support to you, but we really would prefer that you benefit from the federal extra help program, so that we are able to reserve our precious resources to those who are above 150% and don't have access to that program.
Okay, thank you. And then a follow-up to Jalpa. With regard to smoothing, Jalpa, the captain, the smoothing, how do we get from what you've laid out about smoothing, I know Amy's contributed to it as well, to success in smoothing? Like, how do we get from here to, we thought about this and now it works? What's between point A and point Z?
That's a great question, Cliff. I think the first step is right now, CMS is trying to figure out the implementation guidance around the smoothing component of the program. The one thing that I want to kind of raise as a quick issue, though, is that the smoothing option is an option, a voluntary option under the IRA. So it is not that every beneficiary gets automatically enrolled in it. And so one of the key pieces where is going to be really important in terms of the implementation is making sure that the patients who need it the most are made aware of the existence of this option. And the other piece here is that we also need to make sure that given the changes that have occurred under the Inflation Reduction Act, that in other parts of the Medicare Part D benefit and the liabilities of the plans in terms of how much they pay for the costs in the catastrophic coverage period, there is also a need to make sure that there aren't any unintended consequences created by other changes in the IRA that result in restrictive access to specialty drugs. So what we might be having is the smoothing component is going to actually ease up the access barriers. But then there are all these other changes in the IRA that might increase the barriers. And we just don't know what the net effect might be. And this is why my team plans to kind of continue to doing not only supporting the implementation, but actually doing the evaluation after the smoothing component and the other parts of the IRA are implemented to give timely feedback to CMS and the policymaker.
Great answer to the question. Thank you very much. Right on point. Quickly, John, in just a minute or so, can you say anything on behalf of your member companies about their how far along they've come in understanding where the disparities lie, and they're thinking strategically about copay assistance or other ways in which the companies, can work with Amy's outfit or others? Do you think there's like a uniform awareness among your member companies, or some are a little bit ahead of the curve compared to others in thinking along these lines?
Well, it would be hard to answer that question in 45 seconds because it is so all encompassing. And I go back to the research seminar where we did that. I feel like some were looking at it from a care perspective, and then others were looking at it from a benefit design perspective, and they're all in the room. So they're all learning from each other. So I feel like, of course, every company has to do things that make the best decision for their business, their product portfolio, et cetera. But it is something that the industry writ large cares about and quite frankly has an insatiable appetite for, which I feel like is a good tee up for the next panel, right? Because you can't talk about value if you don't talk about equity. And many of our members and we are also very engaged with IVI, who you have on panel 4. So it's a big rock to roll uphill, and I'm glad that our members are such important partners.
Well, John, thanks very much. And we also hope that your research agenda and the research that you carry out feeds back to your members insofar as how they do design various types of assistance and try to do their best to improve access. So thank you very much. Well, Jalpa Doshi, Amy Niles, John O'Brien, you laid out pharmacoequity sure enough for us, and it was great to have one of the people that was there at the beginning, and Jalpa, and someone like Amy who has really made it work in the field and continues to help folks, and John O'Brien, we hope is pushing his companies to stay on the research and make use of it in the real world. Thank you all very, very much.